All right, so we're going to keep along on schedule, and the next presenter is Dr. Colleen Cotton, who I believe is coming to stage. I haven't got to meet her yet. Hi, Colleen. And she's going to talk to us about hidradenitis, which I know can be a tough thing to treat in these patients. All right, welcome. Nice to meet you. It's been 20 years.
Let's see. All right. Hi, everyone. Nice to meet you. I'm Colleen Cotton. I am a new pediatric dermatologist at Children's National Hospital. I started in September. And we're going to talk today. Yay. And I am very excited to talk to you today about something that I feel very passionately about, which is hidradenitis suppurativa, or HS, in the pediatric population. And part of the reason I feel so strongly about this is that we are going to be starting a multidisciplinary HS clinic at Children's. It is the first pediatric multidisciplinary HS clinic in the United States, which we're really excited about, and we'll talk a little bit more as we go through. So we're going to start kind of with a case to sort of think about this. So you have a 12-year-old female in your office, and she kind of mentions it's a hand on the door kind of complaint, that she's had several boils under her armpits for the last year. And in between episodes, there's no pain, no drainage, there's nothing else really going on. Mom also has boils like this that she's never seen a doctor for. Of note, the patient's BMI is greater than the 99th percentile. And she's been told, yeah, that's probably why you're having these. It's very difficult to clean when you're overweight. So that's probably what's going on. So she's wondering if there's anything else she can do to help with these spots. So we're going to do a poll. So which of the following is true about this condition? Is it A, this disease is caused by sweat gland dysfunction? B, poor hygiene does contribute to this condition. C, it is impossible to tell at this point if this is a recurrent infection. D, women are more likely than men to develop this in adolescence. Or E, surgery at this point is the most appropriate therapy. So you can go to the poll link here to answer. Okay, it looks like D is winning, with A being a close second. Okay. So we'll tell you the answer at the end, but you guys did get it right. So what is HS? There's no colloquial term for HS. Like when I talk about atopic dermatitis, I can talk about eczema. When I talk about psoriasis, people usually have some vague idea what I'm talking about. When I say hidradenitis suppurativa, they're like, I'm sorry, what did you say? So what is it? It's important to know what it is and what it is not. And our understanding of that has changed over the last 100 years and definitely over the last decade. So it is an inflammatory skin condition. There's dysregulation of the inflammatory immune response in these areas, and that leads to these painful boils and nodules that occur in the skin folds. It is not an infection. Even though we often use antibiotics to treat this, those more for its anti-inflammatory properties and dysbiosis properties, but it is not an infection. There's not a problem with their immune system not working well enough. It's just not working correctly. The cause is multifactorial. So, and the amount that each factor plays for each individual person is probably different. So follicular occlusion, hormones, obesity and insulin resistance, bacterial imbalance, all of these play an important role. It's not the result of poor hygiene. That has nothing to do with it. It does not contribute to this. And it's one of the reasons that patients fail to come seek care as their disease worsens, because they're told this at the beginning, or they assume this and they're embarrassed about it. And they don't want to go to the doctor and be told that they're dirty and they're not doing a good enough job taking care of themselves. It's also not actually a disease of sweat glands. We thought this for a really long time. Apocrine glands probably play a role in HS, but we think it is more of a follicular disorder now rather than an apocrine disorder, because yes, there are skin folds, the underarms, the groin, these are the typical areas we see it, but you can see it outside of these areas as well in places where we don't have apocrine glands. You can still get HS there. It is a chronic condition and gradually progressive with periods of flares and improvements. It's not an acute disease that like happens, and when it's not happening, it's just not there. So those are some important things to understand about it. Also, when I introduce myself as in a dermatology setting, I say, oh, I'm a pediatric dermatologist, I'm interested in HS. They're like, oh, I didn't know kids could get that. That's really interesting. And the fact of the matter is it's not as common overall in children as it is in adults. The estimated prevalence in the United States in adults is overall, and is anywhere from 0.1 to 2% of patients. The overall prevalence in pediatrics, if we're including like 0 to 18, is 0.028%. But that number goes up to pretty much the adult population when we're looking at African American or biracial female adolescents aged 15 to 17 years, which is our highest risk area. And over 50% of adult patients, when asked, reported that they had symptom onset between the ages of 10 to 21. So we're probably missing a lot of these patients. It's probably an under-recognized condition. Pediatric HS also has some different history and epidemiology than adult HS. So the ratio is 4 to 1 female to male in pediatrics. It's not quite that strong in adults. And what's interesting is depending on where you look in the world, that ratio can reverse. So in Southeast Asia, it's mostly a male-dominated disease, and females very rarely get this. And we really don't fully understand why that is. There's probably some lifestyle factors, genetic factors, but it's kind of interesting. 41% of pediatric patients will have a family history. And I personally think the number is higher because this is not something that people talk about. And if you know that somebody has these, their HS is probably pretty bad, that you actually have an idea that a family member had this. Often when I'll ask, does anyone else in the family have this? I'll get an answer, no, not that I know of. They come back for their follow-up visit and they're like, I was talking about about what she's going through, and her auntie told me that she's had this for the last 15 years and never said anything. So if you can make this diagnosis in kids, you can actually also help adults and who might have gone undiagnosed this entire time. There's also a 2-year delay in diagnosis, which is different from adults, where it's been reported for on average 7 to 10 years from the onset of symptoms to receiving their diagnosis. So the question in pediatrics is, okay, we're doing pretty good. Is this really a delay, or is it just that it's hard for us to make this diagnosis? We need that pattern of recurrence in order to make the diagnosis. We're going to talk about some of the characteristic skin lesions that HS has. So this is an example of some open comedones. If you see blackheads outside of the face, the upper chest, or the upper back, that is most likely HS unless proven otherwise. It's this blocking of the hair follicle with this keratinaceous debris that ultimately then can get stuff trapped under it. It gets inflamed and leads to these other lesions. But you shouldn't really see these in healthy skin. So if you see these, it's a clue that that's what you're dealing with. Inflammatory nodules are the thing that comes next, and sometimes they can even have this ulcerated or eroded appearance to them. These are often very painful, but occasionally I find kids who are like, yeah, no, that doesn't bother me at all. So it's important to look as well. And then abscesses can happen rarely, and this is when things get really out of hand. They can have very significant surrounding redness and potentially cellulitis. This is probably the biggest abscess. This is an underarm. And she actually had a second abscess on her upper arm. This is probably the biggest one that I have personally incised and drained. But this is when it actually fills with pus, which a lot of times those inflammatory nodules are just that, they're inflammatory. There's no pus to actually express from them. Scarring is also a hallmark of HS. In one study looking retrospectively at almost 500 pediatric HS patients, half of them already had permanent scarring by the time they presented to a dermatologist. This can happen very quickly in the course of disease. So it's something that you want to be on top of and recognize. And then gradually over time, these scars can form sinus tracts, actual tunnels underneath the skin that are epithelialized and have this like gelatinous goo inside of it. And these actually promote inflammation. So once those develop, it will make their HS even worse. And there's nothing to do at this point but some type of surgical procedure, which we'll talk about later. But this is what we're trying to prevent in these kids. This is the one question. Just ask this one question. Have you had 2 or more outbreaks of boils in the underarms, the groin, the buttocks, or under the breasts in the last 6 months? I'm going to put an asterisk next to 6 months. In adults, if you ask this question, it is 96% sensitive and also fairly specific for having HS. Now, in kids, I said I put an asterisk next to the 6 months. Why is that? So pediatric patients might not fulfill diagnostic criteria right off the bat. They have the characteristic locations, usually the underarms, the buttocks, the groin, under the breasts. Occasionally other skin folds can be involved, like the posterior neck, behind the ears, areas like that. And you have the characteristic lesions that we went over. But the history of at least 2 within the last 6 months is often lacking. Now, if you extend that question to in the last year, you can catch up to 80% of those patients who you might not have gotten with the 6-month question. So in pediatrics, we probably have to adjust that a little bit. We don't have data on the sensitivity of that question in children, but it's a pretty good one to pop out and use if you see something and you're like, I'm not really sure. Ask that question and it can help you. Making this early diagnosis is the key to altering this disease trajectory. We have this window of opportunity where we can treat and actually change the course of the disease. Because over time, when you have these abscesses and nodules, you get accumulation of scars, sinus tracts, they become physically impaired, it's extremely painful, they're limited in their mobility. But if we can get them before those sinus tracts start to form, before there's significant scar tissue, our therapies work better and their outcomes are better. So it's really important to refer these patients early and start treating them early in order to prevent these kinds of poor outcomes. When you Google HS and you see these like horrifying underarms that are just like a knot of scars all the way down, it doesn't have to be like that. And so when you have severe HS, don't be this guy. Just don't do that. We're going to talk about what we could do. But this is not going to cut it. So first off, okay, let's say I've asked them about these multiple outbreaks and they're like, yes, I have had that. I have it on my bottom. And you're like, okay. Well, is it folliculitis or is it HS? I don't know. And it can be really hard to tell. Sometimes I don't know. And I tell patients that. I'm like, I'm not sure which one of these you have. One of your clues, though, can be these open comedones. So again, if you're really looking for these, you can find them. And in this patient, you can actually appreciate they're kind of next to each other. They're forming baby sinus tracts, baby tunnels at this point. And you can see how that could progress and become much larger. Folliculitis also tends to be smaller, more like definitively folliculocentric spots. You might occasionally have 1 or 2 deeper nodules, but it's much less common than the superficial pustules and papules that you'll see. And then sometimes it's just really hard. Sometimes they can have both. particularly if your patient has Down syndrome. Down syndrome patients are at much, much higher risk than the general population for follicular disorders and HS in particular. This is a patient with folliculitis and HS who also happen to have Down syndrome. And you can see kind of in the upper right-hand area, there's some of those more superficial papules and pustules that look more like folliculitis, but then we have these multiple deeper nodules, as well as some old scars and potentially syringomas in these areas. So there can be a lot going on. How do I know if it's not an infection? Like, how do I know that this isn't an abscess? So there's some clues that we can use to help distribute. So look at the location. Generally speaking, an abscess is going to happen like any random spot, or if there was a site of trauma, whereas HS is almost always going to be in a skin fold or an area of friction. You can culture it. You can do a bacterial culture. HS is generally going to either show no growth, or it's going to show multiple organisms. It's going to be normal cutaneous flora, something like that. If you have an abscess, an infectious abscess, that generally is going to grow MRSA. Not always, less commonly there's some other things, but it'll grow a lot of one particular type of bacteria, not a whole bunch of a little bit of things. You can get staph from HS swabs, but it's less common. There also may be some pustules around an infectious abscess, and you can still see pustules in HS, but look for those other clue lesions, the comedones, the sinus tracts, the scarring that shows this has happened in this area before, to try to make that diagnosis. And then recurrence, like we talked about, like rarely, even if you have like MRSA colonization and you're having multiple abscesses, rarely is that going to be in the same spot. It's generally going to be in different areas, whereas HS is generally the same spot over and over. So these are some examples. This on the left is actually an infectious abscess, and you cannot tell the difference just from like a picture. On the left, that could just as easily be someone's first flare of HS. But on the right, you can tell that there are open comedones, there's sinus tracts, there's scarring, there's an inflammatory nodule. That's definitely not an infectious abscess. Luckily, if you can't tell the difference between folliculitis or HS, the treatment is the same when they're both mild and look the same. Generally, you want them to be on a maintenance antimicrobial wash, and these slides are going to be available, but also we've worked to put together an algorithm for how to manage mild, moderate, and severe HS patients that will be available to you guys. Shout out to Dr. Alicia Tucker again. She does everything, and she helped with that as well. But topical antibiotics can be helpful. Clindamycin is the one that's most studied. Does it really work? Not totally sure, but we do it. And it's best if you pair that with benzoyl peroxide in order to prevent the risk of developing resistance to that clindamycin. For flares, when they're saying like, I have a really painful spot, we'll often consider 2 to 4 weeks of oral antibiotics as a flare plan. Typically we use doxycycline, but occasionally we'll use things like Augmentin or oral clindamycin as well. And then pain management. Talk to them about pain, because they may not know how much ibuprofen to take, how much Tylenol they can take. I'll often give people prescriptions for 800 milligrams of ibuprofen because a lot of these patients are adult sized, and they say, yeah, I'm taking ibuprofen for this. I take 1 tablet because they're 14 and they don't know that they can take more than that. And this same plan will generally work for folliculitis. The difference is folliculitis will generally go away and stay away if you use this maintenance wash. HS will still have periods of flare-ups and may progress further. So let's get into the point of why I'm even here talking to you during this conference. It's that comorbidities are seen in pediatric HS at a similar rate to adults, and that is high. There's a high rate of comorbidity. This causes a very high level of systemic inflammation. One thing that used to be thought based on case reports was that, oh, well, if you see HS in a kid, then you have to worry about precocious puberty, or you have to worry about premature adrenarche. And it occurs, but it's probably not as common as we think. Obesity and overweight, as well as endocrine abnormalities, were the most common in this same retrospective study that I mentioned earlier. The obesity rates in pediatric HS studies range anywhere from 32.5% to 68.7%. So basically a third to 2/3 of kids. But that means that a third to 2/3 of kids are not obese. So it's not just that. It's not because someone is overweight that they have this. And we also don't have good data to suggest if you just lose weight that your HS will go away. These kids are also at risk for hyperlipidemia, metabolic syndrome, acanthosis nigricans, all these other things that we've heard about today. They're at risk for all of those things as well, whether or not they are obese. Just by virtue of having HS, they are at risk for these things too. This is kind of a little, I don't expect you to necessarily read this, but it is a very good walkthrough of how to work up your HS patients for comorbidities. There's a lot of questions here because there are a lot of different comorbidities, and there's a lot of different things to look at in the physical exam. And there's also a lot of different ways that you can go if you're concerned for any of these different things, which is part of the reason why we're starting a multidisciplinary clinic with Dr. Tucker, Dr. Heyer, who is our psychologist. We're going to have her as part of the team, wound care, and outreach to plastic surgery and GI as well, since inflammatory bowel disease is a risk. There's several options that can treat more severe HS and the comorbidities at the same time. This will be included in the algorithm that we give you guys, but metformin, spironolactone, combined oral contraceptive pills. So figuring out those comorbid conditions can really help guide you in terms of, okay, well, what treatments should we try? Because it's a little bit of a mess trying to decide what treatments to use. We're not generally in agreement, and it is about tailoring it to the individual patient. Surgery is also an important part of treatment for HS, and this is something called a de-roofing procedure, where you can see in A, they've stuck a probe in there. That's a whole long tunnel underneath the skin. And so what we do is it's called a de-roofing procedure. We take the roof off of this tunnel and we let it heal in from the bottom up. And these actually do shockingly beautiful. It's much, much better than the giant excision scars that people are sometimes left with. The recurrence rate is lower than excisions, and the healing is generally better than excisions. I do these procedures. There are a couple of others in the area who do them, but they're really great for kids who might have only 1, 2, 3 sinus tracts. They don't have an entire armpit full of scarring. And then we also need to talk about the effect of HS on quality of life. So over 50% of patients reported feeling extremely embarrassed, anxious or nervous, and or down or depressed about having HS in this data that was presented last year at the European HS meeting. And providers also recognize this frequency of psychological distress, but they tend to underestimate it in their more mild to moderate patients. So this is something that even if somebody is considered mild to moderate, that can have a profound impact on the patient. We might be missing that as physicians. So you can help by dispelling myths that these patients might have heard. So it's not an infection. They're not contagious. A lot of times parents, because it does run in families, are concerned they gave this to their child. They did not give it to them in that sense. It's not contagious. It's not a problem with your immune system being weak. I'm often asked, like, well, how can I boost their immune system? And I'm like, you don't have to. Their immune system's actually going a little bit overboard. Better hygiene will not stop HS, and losing weight will not cure HS. So it's something that we talk about, but it's not something that we put a lot of pressure on or make people feel guilty about. You can also talk to parents about school. You, as their physician, have a lot of power to ask these questions. I give all of my HS patients a note to sit out of PE or sports whenever they're having a flare, because it's really embarrassing for them to have to go to the teacher and say, like, I can't walk because I have a boil between my thighs today. Can I not do that? And kids tend not to use them unless they need them, because they want to be like everybody else. They want to participate in things. They don't just want to sit on the sidelines and have people being like, oh, great, she's sitting out again. 504 plans, homebound services, educational letters for school. These are all things that are resources that you can do to help your patients because their school doesn't understand what this is either, and they might need some help. And then lastly, you can direct patients and parents to support groups. These are some examples. The HS Foundation is also a really great resource for clinicians. There's a lot of publications and resources on their website. And so I hope that I've convinced you that HS is a pediatric disease that you should care about and you will see. And I hope that you guys will send the patients who need it over to my clinic so that we can help them out. These are my take-home points, and I'm happy to take any questions.
It's a great talk. I'm curious, just some of the other things you guys use for everything else, like bleach baths, retinoids, Retin-A, or not Retin-A, Accutane. Like, is that kind of stuff being looked at too for this?
Oh, it's such a good question. Accutane doesn't really work. We don't know why, it just doesn't seem to really work. It works for the severe acne in some patients who have that also, but it does not fix their HS. We're still trying to figure out which patients respond to Accutane and which don't. Retinoids are tough because these are skin fold areas and retinoids can be very irritating. So in theory, yes, they could potentially work, but they don't work as well topically. They're often not tolerated. Bleach baths, hypochlorous acid solution specifically has also been shown to help in preventing flares. But there's lots of different treatments, lots of different things out there. If you are interested, I will put in a personal conflict of interest plug. We just published a state-of-the-art review in Pediatrics last month on HS, and there's tons of information on there on all the different treatments that have been looked at and tried and that you can think about. So you can also check that out if you're interested.
Yeah, how often do you use the Hibiclens wash?
How often do you use what?
The Hibiclens wash?
The Hibiclens? So I think it's a personal preference kind of thing. I don't use it as often. I use it if they have a lot of pustules or if they've tried some of the other washes and it just hasn't worked. Benzoyl peroxide is just my personal usual first go-to, but I use it a decent amount. If a patient comes to me on it and they're like, yeah, I feel like it's helping, I'm not going to take them off of it. Every day. Yeah, if tolerated, which they might not be able to, it can be irritating. So a minimum of 2 to 3 times a week if they can't do it every day.
There is a significant element of mental health overlay in this. Question related to, 1, is there an increased incidence of suicide? And 2, what do you do about suicide screening?
Good question. So I'm trying to remember the exact data because I think that in pediatrics, the increased suicide risk, I can't remember if that's been shown or not, but there's absolutely an increased risk of depression and anxiety and other mental health disorders outside of the quality of life issues. And there's probably something biological going on with that beyond just like, oh, I'm sad because this disease is so terrible. We do, that's part of the reason we have a psychologist as part of our multidisciplinary clinic. And I do screen at least all of my moderate to severe patients with a PHQ-2 and then a PHQ-9 if it's appropriate. Because I did have one patient who I missed that she was suicidal, and luckily she did not complete her suicide attempt, but that was really hard for me to be there with her in the ER and know that I hadn't asked her that question, and I might have been able to catch that earlier.
There aren't that many pediatric dermatologists out in the community. No, it's a reality, and but my question is, we almost all have general dermatologists pretty available to us. Is the average general dermatologist, and I know this is a value judgment question, going to be familiar with this?
Yes and no. I think that there are some dermatologists out there who do a great job with HS, and there are some dermatologists out there who just don't want to deal with it. They're not necessarily up on the most recent things. So part of it depends on how comfortable they are with HS. And part of it depends on how comfortable they are with pediatric patients. I have some dermatologists who will not put a pediatric patient on a systemic medication of any kind because they're like, oh my God, that's terrifying. And to me, that's doing them a disservice. So you kind of have to feel out the dermatologist, and you can have your patients kind of give you that feedback. Do you feel like you had a good experience with that dermatologist? And if they didn't, feel free to send them to somebody else, because they might be doing a great job, but it never hurts to get a second opinion.
Over here. Up to what age group do you see? Do you go up to 21 in your clinic? That's one question. And the second question is, do you recommend laser therapy as well? I know some hospitals were using that experimentally because it wasn't covered by many insurances. Of course, prior authorizations were required.
Yeah, great question. So currently the official stance is that new patients need to be 18 or under, but for the HS clinic, likely we will be taking patients up to 21 years old. We still have to kind of make that official or not, but you guys this is my contact information. You are welcome to email me about any particular patient that you have, and I'm more than happy to work with you. We also have partnerships with a lot of the other dermatologists in the DC area who take care of HS, because we will need to transition these patients. So I'm happy to hook them up with somebody if they're beyond that age range. The second question, laser hair removal in particular, very hard to get covered by insurance, but likely extremely effective. And I wish we could do it more. From a financial standpoint, it's very difficult, especially with facility fees and stuff like that. But there are some places in the area that do that. And I do recommend that, particularly for my mild to moderate patients. It can really help them out as well. Thank you.